Uh, as we just finished our MD examination last month, and we know that newborn case is having a lot of importance. Uh, there is a significant marks allotted to newborn case. So it's very important that we should discuss newborn cases in this platform. So today the case is presented by Dr. Jose, who is the junior resident in IMCH, and discussion is by Dr. Babu Francis, who retired from Department of Pediatrics, Government Medical College, Kozhikode, and now working as professor in Malabar Medical College, Kozhikode. And Dr. Deepa KS is the assistant professor in neonatology, uh, and we expect a active discussion here. And now you can take over, Dr. Jose, Deepa, Babu sir.
Okay, good evening all. We shall straight away start. I invite Dr. Jose to start his presentation. Dr. Deepa will be the primary discussant. I will assist her. Okay. Deepa, ready alle?
Good evening, senior faculty members, respected teachers. Sir, I'll assist you, sir, because PG exam is
I will assist you,
today.
Deepa.
So,
Okay. Let him start.
yeah.
Okay.
Joe's ready?
നമ്മൾ എത്ര ടൈം അതിന്റെ ടൈം എത്രയായിരുന്നു
45 minutes.
ടൈം
45 minutes അല്ല 9 o'clock വരെ
Up to 9 we have time. Up to 9 o'clock.
9 o'clock ഉണ്ടോ?
Up to 9 o'clock. Yes.
Sir, able to see the screen? Hello, sir.
Okay. Joseph തുടങ്ങിക്കോളൂ.
Sir, able to see screen?
Yes. Yeah. Screen is visible.
Yes.
Clear.
And everybody else, please mute. Okay. ജോസ് പറയുന്നത് കേൾക്കുന്നില്ലല്ലോ, കേൾക്കാമോ?
ജോസ് പറയുന്നത് കേൾക്കുന്നില്ല.
സ്ക്രീനിൽ ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല സർ.
അല്ല,
ഞങ്ങൾ കാണുന്നുണ്ടല്ലോ.
സ്ക്രീനിൽ ഞങ്ങൾ കാണുന്നുണ്ട്, വിസിബിൾ ആണ്.
കാണുന്നുണ്ട്. ന്യൂ ബോൺ കേസ് പ്രസന്റേഷൻ എന്ന് എഴുതിയിട്ടുണ്ട്. ആ സ്ലൈഡിലേ ഇട്ടിരിക്കുന്നത്.
സെക്കൻഡ് സ്ലൈഡിലേക്ക് പോകാൻ പറ്റുന്നില്ല.
അപ്പൊ you just log out, not logging out. You just stop screen sharing.
ലോഗ് ഔട്ട് ചെയ്തിട്ട് വീണ്ടും ജോയിൻ ചെയ്യാം കേട്ടോ. ഓക്കെ.
By that time, ദാസേ ദീപനെ ഒന്നുകൂടി ഇൻട്രൊഡ്യൂസ് ചെയ്താൽ മതിയായിരുന്നു. ദീപ PGസിന് അധികം ആൾക്കാർക്ക് അറിയണ്ടാവില്ല ചിലപ്പോ.
Dr. Deepa, she is trained from St. John's. DM trained from St. John's. And she joined in 2020, I think, Calicut Medical College. Technology.
Yes.
Deepa, you can self-introduce the other things.
So that's all, sir.
She did her MD from SAT.
Yes.
SAT MD കഴിഞ്ഞു അല്ലേ? Okay.
Hello, sir.
Yes.
Okay.
Good evening to everyone. I am presenting a case, newborn case. Presenting complaints, baby of Khadija Harris, 24-day-old male baby, on preterm at 30 weeks plus 5 days, to 31-year-old G4P3L3, and post-menstrual age 34 weeks plus 1 day, delivered via preterm vaginal delivery on 23rd 2nd, 2025 at 3:18 p.m. Baby cried soon after birth and birth weight of 1.345 kg. Baby admitted in NICU in view of respiratory distress soon after birth. Informant is mother and the history is reliable.
Just 1 minute. Deepa, shall we break after each slide, or is it better to break after each slide and discuss and then proceed?
I
What do you think?
think so, sir. I think so.
Okay. I shall start, and Deepa, you continue. That is regarding this is a preterm birth. So you are called to the labor room. The neonatologist or pediatrician on duty is called onto the labor room to attend the delivery. Okay. So what are the tasks in the labor room for the neonatologist or pediatrician resident on duty? Those can explain.
Initial prerequisites are needed in terms of equipments as well as a team needed for the resuscitation. So one team will be ready for the resuscitation in view of preterm baby, and also equipments regarding resuscitation. A warmer, a pre-warmed warmer will be there, and there will be resuscitation bag and mask ventilation equipment, as well as laryngoscope for preterm babies, suction catheter, and
just one thing, because I was hinting what all additional things you may need for this particular baby. You know that the baby is going to be a very preterm baby, that is around 30 weeks according to the EDC. You expect a preterm baby, very preterm baby.
Okay,
so what are the additional things you need to, equipment you need to arrange? That is, you can, in the order you can go, like the temperature, like airway, breathing, like that, you can go. That way you can remember it better. So what are the additional things you need for temperature maintenance?
In temperature, pre-warmed radiant warmer needed nearly 100% with a 100% heater output for 10 minutes. That needed, and also the labor room temperature will be around 26 degrees Celsius, and also we need an incubator to transport the preterm baby to NICU. This all regarding temperature, and also plastic wrap,
Cling wrap.
Cling wrap also needed, or external thermal mattress if present. It will be good for prevent hypothermia.
Jose, can you just tell us about the recommendation, like which all babies would you prepare yourself for, like cling wrap or warm mattress, no plastic wrap? Which all
less than 32 weeks gestational age, we uses this cling wrap.
Less than 32 weeks.
weeks.
Yeah.
Then
so
also,
that is one extra thing you need to be prepared for when you're anticipating a smaller baby, no preterm baby, with respect to warm care. Then further moving down, and transport incubator.
Transport incubator. For a respiratory support of the baby, we need a blended oxygen and air source for initial resuscitation, and also oxygenation to be monitored by a pulse oximeter. And in view of preterm delivery, we uses 21 to 30% of oxygenation, and also we need a TP's resuscitator, resuscitating machine for baby to give positive pressure ventilation.
So given a choice, you have a bag and mask and you have a TP's. For this particular baby, which one would you prefer and why?
TP's resuscitator will be preferred because controlled ventilation can be given.
In what way?
We are giving peak inspiratory pressure. Positive and expiratory pressure 5 centimeter water, and PIP around 15. That will be delivered via TP's resuscitator. In view of in another case, bag and mask, we will not having that control of ventilation pressure.
Can you be more specific? Like, what is the most important thing? Someone has put in the chat box. What is the most important thing you would like to have with respect to your preterm initial resuscitation, positive pressure ventilation? What is the extra thing you are providing with TPs? What is the extra support you would like to give when compared to bag and mask?
PIP can be given by TP's resuscitator.
PIP. Yeah, go on. Yeah, so most of them have answered.
Coming to maternal details, baby born.
No. So we are still, we have anticipated a preterm delivery, and so was asking about the preparedness in the labor room. So with respect to a preterm delivery, what are the additional preparations you need to take? That is what we were discussing. So we spoke about the thermal control, the extra thing you need to have. Then second was a provision for a blender, if it is possible, if it is available, that is the ideal one. Then provision for a PEEP, no? That is via TPs versus bag and mask is not the one which is preferred in preterm population, preterm resuscitation. Yeah.
Jose, if you are having a good connection, it will be better to switch on the video also. Jose. If the net connection is good, Jose, you can switch on the video also.
Yes.
ഡിസ്റ്റർബൻസ് ഉണ്ടല്ലോ അല്ലേ? ജോസ് പറയുന്നത് ക്ലിയർ ആണ്. ഓക്കെ, അതിന്റെ ഇടയിൽ കുറച്ച് ഡിസ്റ്റർബൻസ് വരുന്നു.
വീഡിയോ ഓൺ ചെയ്യുമ്പോൾ സ്ക്രീൻ പോകുന്നുണ്ട്.
ഇല്ലില്ല, സ്ക്രീൻ കാണുന്നുണ്ട്, ഞങ്ങൾ കാണുന്നുണ്ട്. ഓക്കെ, ഐ ഡോണ്ട് നോ, പ്രോബബ്ലി യു കൻ നോട്ട് ചേഞ്ച് ദി സ്ലൈഡ്.
Yes sir.
Okay, you just continue, no problem.
Okay. After that, the one incubator needed for transport of the baby, and also
do you have any other equipment? Are you able to hear me?
We request all of you to mute other than Jose and sir, because we are having disturbance, we are facing disturbance.
Hello sir.
Am I audible?
Suction equipments we needed.
അല്ല, സെക്ഷൻ അല്ല. ഞാൻ ഒരു കാര്യം ചോദിക്കാനാ. Apart from TP's resuscitator utilized in the labor room?
Sir, unable to hear.
Sir was asking what else you get ready in the labor room in case of a preterm delivery.
അല്ല, ഓഡിബിൾ അല്ല, ഞാൻ പറയുന്നത് ഓഡിബിൾ അല്ലേ മന്ദസ്? My question is, what other respiratory support equipment can be utilized in the labor room in this scenario?
Intubation equipment.
No. I mean, no. For equipment for respiratory support, just like TP's resuscitator, what other equipment can be used to provide CPAP for this baby?
Bag and mask ventilation.
No. That you already mentioned. With the bag and mask, you cannot provide CPAP. That madam already said. So what other equipment you can use to provide CPAP in the labor room?
Oxygen with flow meter and
it's a flow inflating bag resuscitator. You can utilize for providing CPAP.
Okay sir.
Okay.
Then intubation.
Continue. What other equipments?
Intubation equipments needed. Laryngoscope with straight blades. In case of preterm, uses number 0 blade, and also endotracheal tube of internal diameter of 2.5 size can be used. And also medication should be available there, like epinephrine and also normal saline.
Can you tell me one indication where you may need an intubation and surfactant administration in the labor room itself?
Less than 28 week and they have not received antenatal steroids. Within 15 to 30 minutes, they needed surfactant administration. Sir.
Okay. Deepa, would you like to add?
Yeah, but in this, sir was asking about the indication for prophylactic surfactant in labor room.
Yes.
Yes, ma'am. Yes, less than 28 weeker with not received antenatal steroids or incomplete antenatal steroids received can be given prophylactic surfactant within 15 to 30 minutes after birth.
Way, like incubation, in a severe RDS, you may straight away give after recruiting the lung, you may provide intratracheal.
There's some issue with the audio, sir.
And the audio കേൾക്കുന്നില്ല.
ഇടയ്ക്ക് ബ്രേക്ക് ആവുന്നുണ്ട്.
ആണോ? ഓക്കെ. വീഡിയോ റെഡി ആണോ? ഇപ്പൊ
So, Jose, we were discussing.
ഇപ്പൊ audible ആണോ?
ഇപ്പൊ audible ആ, sir. Better, sir.
കുറവാണോ? ഓക്കെ. വീഡിയോ കട്ട് ചെയ്യാം.
Yes, sir.
Continue.
Ma'am? Yeah. In anything with the cord management, would you like to add?
In case of if baby is not cried soon after birth, immediate cord clamp is needed. If not, if baby is cried, we can delayed cord clamping can be done. And
So that is one key point we would like to emphasize on. No, even if this is a preterm baby, DCC should be the practice. Delayed cord clamping. There's no role for immediate cord clamping for a preterm baby. Any baby who has cried soon after birth, as of now, term or preterm, the baby qualifies for delayed cord clamping.
Yes, ma'am. And it will improve the HB and decreases blood transfusion later.
Yeah, better hemodynamic stability. And how much is the delay? What is the recommendation?
30 seconds delayed cord clamping.
1 minute. 1 to 3 minutes, but WHO says 1 minute. Fine. So put together all these, whatever interventions we have described, what is the broad terminology under which all these come for a preterm baby management in labor room? For any baby, we should be, especially for preterm babies, this is called the golden hour management, no?
Golden hour management.
Yeah. So where we should be supporting the baby adequately soon after birth, proper resuscitation, avoid hyperoxia. So that is one message we would like to give. Targeted oxygen saturation, provision of PEEP, adequate PEEP. So delivery room CPAP is a norm. And that has prevented so many invasive surfactant administration. So DR CPAP or delivery room CPAP, infection control, strict temperature maintenance. Can you just highlight the importance of temperature, hypothermia, prevention of hypothermia? How is it related to mortality in any baby?
Mortality.
Or anyone from the audience can answer? No PGs are there.
Mortality is 15% decrease.
No, much more than that.
30% decrease, 28%.
Yeah. It is roughly 28%. I mean, close to 30%. So that is the gravity of the problem, no? The increase in mortality is by 30%. So that is the importance of maintaining euthermia. So all these interventions which we do in the labor room, especially for a preterm, that comes under the golden hour management. Okay. Sir?
Yes, ma'am.
Okay, continue.
Golden minute, madam.
So golden minute, golden hour high risk babies നമ്മൾ golden hour.
Resuscitation, but we are talking about for preterm baby golden hour. That is to our resuscitation, including stabilization in the NICU. That is a golden hour. So I think Jose can explain that if somebody is asking about.
Within 1 hour, we anticipated the high risk delivery, and we are able to assist babies breathing and preventing hypothermia, and also early CPAP support, and as well as transport in incubator, and avoid hyperoxia. This can improve, and also delayed cord clamping. This can improve child's.
And one more important thing, may not be in the labor room.
Sepsis prevention.
That is always there.
Yes.
One more thing. Early aggressive nutrition.
Yes.
Initiation of nutrition. Okay. So yeah, we are still stuck at the labor room.
Okay. So we can proceed. Jose can proceed further.
Okay.
Further aspects of first golden hour management, you can say. Madam said about early enteral feeding. What type of enteral feeding will start in this baby?
Expressed breast milk can be given in the first hour, and also total parental nutrition should be started if enteral feeding is not available.
What do you call that enteral feeding? This baby is 30 week, no?
Sir?
Do you start enteral feeding in its fullest sense or something else?
Minimal enteral nutrition.
Okay. What is the ideal thing for initiating minimal?
Within 1 hour. Hello, sir.
Yeah. So as early as possible.
What do you start with?
Hello.
What do you start with?
Expressed breast milk. And
what is the first express? What do you call that? First
cholesterol.
Cholesterol. Okay.
Okay.
Okay. Sir. Hello, sir.
Yeah, Jose, you can move on.
How early you can start?
Sorry, sir. Sorry.
You can start minimal nutrition. Kakao, Jose?
Yes, sir. Yes, sir. With as early as possible. If any abnormal Doppler or
from what degree? That is next.
Hello.
Sir, voice break ആവുന്നുണ്ട് sir. Sir is not audible. So Jose. So it is always express breast milk, and important terminology is mom, mother's own milk, colostrum. So yeah, so that is again part of golden hour management of our preterm, or for that matter any baby. So yeah, we can move on to the next.
Okay. Coming to maternal details, baby born to non-consanguineous parents, 31-year-old mother and 35-year-old father, G4P3L3, history of antepartum hemorrhage, in view of low-lying placenta, minimal bleeding noted. There is no history of any chronic illness or medication for mother, no history of diabetes or hypertension or hypothyroidism. Coming to antenatal history, pregnancy detected by UPT after 1 month of missed periods. It was a booked case and had regular antenatal checkup, and mother blood group was A positive. In first trimester, mother started taking folic acid from 2 months of pregnancy. screening were done, which was normal. There is no history of fever with rash or radiation exposure. And vaginal bleeding, not in the first trimester, or any drug intake in the first trimester. USG done was told to be normal. Coming to second trimester, quickening felt at the end of fourth month. First dose of TD was taken. Iron and calcium tablets taken from fourth month onwards. There is no history of pregnancy-induced hypertension, bleeding or leaking PV, or hypothyroidism. Anomaly scan done at fifth month was told to be normal. There is no history of fever, abdominal pain, or burning micturition. No history suggestive of UTI. And in third trimester, continue to perceive fetal movements normally. There is no history of gestational diabetes mellitus or pregnancy-induced hypertension or hypothyroidism. And mother having antepartum hemorrhage in view of low-lying placenta noted on 25/2/25 and admitted in IMCH high dependency unit in view of bleeding per vagina. Mother received 2 doses of injections which were told to be improve lung maturity in baby.
Can I make a comment? The thing is, for your examination, newborn case will be a short case, and here it is a preterm baby. And if you, from your history, if it is very clear what is the reason of preterm labor, then you need not stress more on this history of UTI and all. If it is not clear, okay, all these details are needed. But here it is, there is antepartum hemorrhage and all, so the cause of preterm birth is known here. So I think you need not spend more time on other causes of preterm labor.
Okay, sir. Okay, sir.
So, Babu sir, Babu sir,
You can take over, no problem, Deepa.
Jose, so what are the antenatal interventions? Like you are in the referral hospital, you are the gynecologist. So what are the things from your side you would be doing to improve the outcome of this? Because you are anyway anticipating a preterm delivery. Yeah, this lady has got an antepartum hemorrhage and a placenta previa. So what are the measures you would take as a gynecologist to improve the outcome of this baby?
Giving in utero transfer to the higher center.
Yeah, sure. That is very important. So that it is definitely in utero transfer.
And then antenatal corticosteroid should be given to improve the baby's lung maturity and also prevent IVH, intraventricular hemorrhage, and also necrotizing enterocolitis can be prevented by giving antenatal steroids. And also give magnesium sulfate for neuroprotection.
So what is the, can you just explain the antenatal corticosteroid part? Which one would you prefer? And
betamethasone preferred 24 hours apart, 2 doses. And
why so? Why do you prefer betamethasone?
Only 2 doses needed. And
what is the recommendation?
Between 24 to 34 weeks.
As per WHO.
As per WHO, we should give antenatal steroids. And if after 14 days, we can repeat the steroid dose if not delivery occurred. And betamethasone has advantage of long half-life.
Yeah, so we are clear on which is the population you need to give as per WHO. There are controversies, there are evidence for late preterm, but we'll not go into that. So as per WHO, it is for 24 to 34 weeks. So who to give, we know. And what is to be given is the topic we are debating on. So what are the approved steroids which you can give for ACS, that is antenatal steroids? You mentioned about betamethasone. Any other steroid?
Dexamethasone.
Dexamethasone. So yeah. So whatever the studies know, they have not proved one is better than the other. And slightly there is a controversy with respect to betamethasone. What is that? So, because whatever studies they have done on betamethasone, it is on a different salt. So, it is on betamethasone acetate phosphate, and which is available in India is a different salt. So, we are not sure of how this particular betamethasone phosphate is going to act and what is the effectiveness. So, however, so that is why, and what is the extra advantage of dexamethasone? Not with respect to the efficacy, but what is the other thing? The important thing, which is especially in low middle income countries, with respect to dexamethasone. It is cheap. It is easily available. It actually comes under the essential drug list. So it has to be there in all hospitals. So even if you are seeing the lady in a peripheral hospital, they'll have a stock of dexamethasone. So, effectiveness wise, there's no difference between dexa and beta. And whatever is available freely and lower cost is definitely dexa. And the cumulative doses?
4 doses of dexamethasone needed.
Yeah, and the cumulative dose, be it betamethasone or dexamethasone, we are targeting at a dose of 24 milligrams.
24.
Yeah. So any other, so that is one thing. So to optimize the outcome of a preterm birth, one definitely is antisteroids. What is the other thing?
Neuroprotection.
Yeah.
For neuroprotection, we give magnesium sulfate.
Which all group would you suggest giving the same magnesium sulfate?
To prevent cerebral palsy. Before 32 weeks of gestation.
32 weeks. So that we should be clear on 32 weeks, and the other thing is 34 weeks. And is there any timeline, like this lady has got pain, but you're not anticipating delivery? Maybe you anticipate delivery only within the next 3 or 4 days. So what is the timeline in which they advise giving magnesium sulfate?
Magnesium sulfate, usually we're giving loading dose of 4 gram IV over 30 minutes, and later followed by maintenance dose of 1 gram per hour up to 24 hours.
Yeah, so
till delivery.
Yeah, till delivery, it is like if
less than 24 hours.
Yeah, if you're anticipating delivery within the next 24 hours, then you're justified in starting giving magnesium sulfate. Okay, so these are the two important antenatal interventions which you as a referring gynecologist would like to give. Any other thing?
Antibiotics, if any preterm rupture of membrane,
because
we should give antibiotics. If UTI, pre-UTI, prevention of sepsis.
And if it is not an emergency, or if you're not anticipating mother's health is not at stake, then probably you can buy time by giving tocolytics as well. So these are the important 4 important things which any referring gynecologist or doctor should know. Give the dose of steroid, start magnesium sulfate. Maybe it may not be possible from a peripheral hospital starting magnesium sulfate, but one thing which all of us should be sensitized. Give the first dose of antibiotics and probably tocolytic.
Yes.
Move on.
Continue. Natal history, baby born via preterm vaginal delivery, 30 week plus 5 day of gestation. Delivered a male baby of birth weight 1.345 kg and born via preterm vaginal delivery. Baby cried soon after birth, and baby was told to have respiratory distress, and hence baby shifted to NICU for further management.
Okay.
And postnatal history, baby was admitted in NICU and has received respiratory support through a machine, and tube was connected to baby's nostril, and also IV medications were given, and also started expressed breast milk on day 1 via orogastric tube, and baby passed the urine and stool within 24 hours of life, and baby's distress improved on 15 hours of life, and baby was weaned off to room air on day 3 of life. Baby's feeds were gradually increased and given via Bogernam. And also baby had jaundice on day 3 and phototherapy given for 4 days and stopped after resolving. Mother's blood group was A positive. And also baby had feed intolerance noted on day 5, and also mild abdominal distension noted, and baby kept on NPO for 2 days and started IV antibiotics for 7 days. Baby is now currently 24-day old, post-menstrual age 34 week plus 1 day. Baby now on expressed breast milk 20 ml via GK plus direct breastfeeding, Gogurnam feed plus direct breastfeed. Current weight of baby is 1.255 kg, and kangaroo mother care started on day 9 of life.
Just can I interrupt? Am I audible?
Yes, sir. Yes, sir.
Okay, okay. So how did you advance the enteral feeding in this particular child? Can you just revise, repeat it? How did you initiate and progress the enteral feeding in this child?
Minimal enteral nutrition started initially as 2 ml, and later 10 to 20 ml per kg per day feed advancement can be done.
For this particular baby, you started on mother's on milk?
Yes, yes, sir. Yes, sir.
Okay. Suppose it is not available in your institution, what is the next choice?
Pasteurized donor human milk can be used.
Okay. So is there an advantage? Suppose both are not available. Is there what else you can do? Do you advise formula feed as an non-nutritional or minimal enteral nutrition? What is your take on that? Will you start minimal enteral nutrition with preterm formula?
Preterm formula feed, minimal.
Will you start minimal enteral nutrition with the preterm formula if the first two choices are not available?
Yes.
Yes, yeah, sure. That is very important to initiate minimal enteral nutrition for gastrointestinal maturation. Okay. Okay, carry on.
Okay.
You started on 2 feeds, no? From which day?
On day 1 of life.
Oh, baby was put on NG2 feeds.
NG2 feeds, sir.
Okay.
And
did you give continuous feeding or bolus feeding? Continuous and did you give continuous NG feeding or intermittent like boluses every 2 hours or 3 hours? How did you give?
Every 2 hourly.
Will you educate continuous enteral feeding, which is better, continuous enteral feeding or the 2-3 hourly feeding?
Intermittent.
Which one would you prefer?
Which is more physiological?
As like baby sucking, but intermittent feeding is advised.
Not sucking, but intermittent feeding stimulates the gastrointestinal enzyme secretion and so on, and motility and so on. Okay, that's good.
Then on.
So how your baby would human breast mother's milk? What are the advantages of human breast milk as far as enteral nutrition in a preterm baby is concerned?
For human milk contain immunity factors for prevention of infection, and also prevent necrotizing enterocolitis by promote gut maturation, enhance immune function.
Okay, anything else you can initiate in a preterm baby? Not immediately, but part of enteral nutrition. What about probiotics? What do you know about probiotics?
Sir,
Probiotics. What do you know about probiotics?
probiotics are beneficial organisms for healthy.
ഏതൊക്കെ probiotics which are first studied for preterms?
Lactobacillus.
Lactobacillus and bifidobacteria. You know what are parabiotics? Probiotics in the concern എന്താണ്? Live ആണല്ലോ അല്ലേ? Live ആണ്.
Yes, sir.
What do you mean by parabiotics?
Non-viable.
Parabiotics കേട്ടിട്ടുണ്ടോ? Parabiotics.
Non-viable.
Non-viable. So you don't have a risk of infection as such. So parabiotics. Then what are prebiotics?
Prebiotics.
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 And normally breast milk normally is it present in breast milk or you supplement it for improving the quality of preterm formulas? Is it available normally? Human milk prebiotics.
Human milk oligosaccharides.
Okay, oligosaccharides. Okay. അതിന്റെ ഫംഗ്ഷൻ എന്താ പ്രീബയോട്ടിക്സ്?
That pathogens protect against that promote the growth of pathogens.
Which pathogens?
Beneficial bacteria, lactobacillus, bifidobacterium.
Yeah, so they're good gut-friendly bacteria, no? May not be pathogens as such.
Yes.
They may prevent the bacterial adhesion, and certain prebiotics can even act as viral receptors, preventing viral infections and so on. Okay, good. Okay, carry on. You continue.
Okay, sir. On day 3 of life, baby developed jaundice and phototherapy given for 4 days and stopped after resolving. And also baby had feed intolerance noted on day 5 and minimal abdominal distension noted and kept on NPF for 2 days. The IV antibiotics started and received for 7 days and then stopped. Baby now currently 24 days old, postmenstrual age 34 week plus 1 day, on expressed breast milk 20 ml via Gogurnam feed plus direct breastfeed. Current weight 1.255 kg, birth weight was 1.345 kg, and KMC started on day 9.
So, what is your comment on the feed intolerance on day 5? What do you think it could be?
In view of symptoms, it could be necrotizing enterocolitis, suspected NEC.
So, day 5 of life, isn't it too early?
Feed advancement.
So we are not very sure on how much feed this baby was on, but this baby being a 30 weeker and
1.345 kg birth weight.
1.345 kg. So what sir was wanting to convey was, I think it's always early aggressive, even early aggressive nutrition as such for all babies, parental nutrition for all babies, for smaller babies for less than 28 weeker. Yes, definitely start on parental nutrition. And that again depends on each unit policy. But equal to early aggressive parental nutrition is the other thing, no? Early aggressive enteral nutrition is also important. So we are actually shifting on to we were very worried about the development of NEC and all those things. So that is why we usually start off with little amount of feed, then slowly advance. But now we are turning on to any stable VLBW babies. We can right away start with full feeds. So that is ETF, early total enteral feeding. That is a new, may not be new, maybe over the past 5 years, the emphasis is on early total enteral nutrition. So again, that depends on the unit policy, the unit feeding policy. The key message is each unit will have to devise their own feeding policy. And the second message probably we would like to say is no babies should be starved. Even if the smallest of smallest baby should be started on some amount of enteral nutrition. So if someone says like 30 weeker, why haven't you started on full feeds? That again, if mother's milk is available, because there are a lot of other limiting factors as well. No, may not be having a milk bank. Mother's milk may not be available at that time. So the full amount of feeding may be difficult to start off, but essential is at least some amount of enteral feeds has to be started, and it has to be advanced rapidly. Again, if the baby is having shock on inotropes, then probably we'll have to titrate accordingly. But this is a general dictum of enteral management, enteral feeding management of a preterm baby, of a stable VLBW baby. So that is one point probably so was emphasizing on.
Yes.
And your comment on probiotics, like not sure how many of the units use probiotic. What is the evidence for probiotic use? What does it prevent?
Aims.
So we have evidence for prevention of NEC and late-on sepsis. Having said that, it is again a unit policy, because you are adding something which is foreign. We are not sure what is the available, commercially available probiotic preparation in the market. So there are a lot of other question marks over there. But as of the latest evidence, we do have evidence that probiotics, whatever study they have done on bifidobacterium as well as lactobacillus. So the probiotic which is available in our with us may not be the exact concentration of the bacteria which and exact concentration or the exact bacteria with which they have studied. So that is a point against, or the debate goes in favor of not using probiotics in many units. So you should know that it's there. It is an evidence approved thing, use of probiotic.
Okay.
One more thing.
Okay.
Sorry, sir.
Continue.
Preterm milk, how is it different from term breast milk?
Preterm milk contain more proteins, and also a lactose content is more in preterm milk, and it's essential.
Definitely protein content is high. Can you just tell us the figure, like
2 gram, 2 gram.
Yeah, it again depends on the mothers, but the early preterm milk, no, day 1, day 2, day 3, and all, the protein content might be high, 2 to 2.2 gram. And what happens to the protein content of preterm milk further on?
Decrease.
Yes, it decreases. So when you have a preterm mother who has delivered, say, 1 month prior, the preterm protein content of the milk is almost equal to the term. That is around 1.1. Yeah. So, so the initial preterm milk protein content is much higher when compared to term, but it almost equalizes to the term protein content by around 3 to 4 weeks.
Okay.
Right. And more importantly, you have lots of bioactive, apart from the protein content, which is higher in preterm milk, you have a lot of bioactive molecules in preterm milk, especially your secretory IgA, all those things that it is found to be higher in preterm milk, which is very, very essential for a preterm baby.
Yes.
Yeah.
Lactose content is more in preterm baby.
Okay.
Just did you start human milk fortifier for this baby HMF?
Yes, sir. After getting,
when did you start?
After getting 100 ml per kg per day, we can start HMF.
Okay. Is it that your policy to be the feeding at 100 ml per kg you start? Is it?
And also birth weight till 2 kg we can use HMF.
Yeah. So HMF you can start when the feeding, enteral feeding around 2/3 of enteral feeding you can start HMF.
Yes.
Okay. What is the dose of HMF available? How do you constitute?
Lactodex.
How much for how many ml of milk? How many sachets?
1 sachet in 25 ml milk. Hello, sir.
Hello.
Sir, one sachet in 25 ml of milk.
Deepa, അങ്ങനെയാണോ?
സർ
Deepa?
നമ്മുടെ ഉള്ളത് ലാക്ടോഡെക്സ് HMF ആണ് സർ. അത് 1 sachet in 25 ml ആണ്.
25 ml ആണ്. Okay. Do you want to supplement calcium and phosphorus when the baby is on full HMF? Or is it required?
HMF contain calcium and phosphorus. And
why do you want to give calcium and phosphorus in a preterm baby?
Sir?
Why do you want to give calcium and phosphorus in a preterm baby?
To prevent osteopenia of prematurity.
What is the dose? What is the dose of calcium and phosphorus when you give enterally?
150 to 200 mg per kg calcium and about half 70 to 110 phosphorus.
Okay. How long you continue that? What is the recommendation? How long you continue?
Till 40 weeks of postmenstrual age.
Okay. Oh, continue. Can continue.
Immunization history, OPV and BCG were given. And family history, no history of any other significant illness in family. Other 3 children were normal. Socioeconomic history, father educated up to SSLC and mother up to +2, belong to upper lower class according to modified Kutusami score. On examination.
What is the relevance of socioeconomic history and mother's education in a preterm baby?
For breastfeeding practices and also prevent sepsis. Environment of the family for supporting breastfeeding and as well as preventing infection.
So the education level, especially if the mother is important. She has to be taught regarding the care of baby, the infection control practices. Apart from that,
increase we can counsel betterly.
Yeah. See, this is an important event in the family, no? And this is especially if you have a smaller preterm baby. So that family support is very, very important.
Yes.
Because entire family has to be taken into the care of the baby. So what is the new concept? What is the new terminology which we have now?
Support
developmentally supportive care is there, but what is the other thing? Because we are talking about the family support. So it is family participatory care, no? FPC.
Yes.
Yeah,
Yes.
Government of India has actually released a FPC guideline also, how to initiate family participatory care. So what is your comment on that? What are the things you can do as a treating pediatrician in ICU to bring in the family to care?
For breastfeeding practices, elder women in the family can be supported for breastfeeding.
Why only women?
Every
I mean, the couple has to be counseled properly, because that psychological support from the husband is also very important. Okay, because what you see commonly is the elderly grandmothers, and they complaining that palilla adalla stiram കാണുന്ന. So
Yes.
it is like we need to counsel them adequately, plus the psychological support from the husband is also important. Then
kangaroo mother care can be given.
yeah, so it is KMC, kangaroo mother care, as well as some people say KFC as well. No? What is
Kangaroo
KFC?
father care.
Yeah, father and anyone in the family. But what are the benefits of KMC with respect to baby, and with from the mother's perspective as well?
Increase the affection between the mother and the baby, and also help to gain weight, and help in thermoregulation. Also prevent infections and hemodynamic stability, cardiovascular stability, and also prevents apnea. Then it also increased the breastfeeding.
Deepa, you are muted.
Yes, sir. So, apart from this, what is the most important thing? That is why the world is in favor of KMC now.
Neurological outcome.
Neurological outcome. So there are a lot of evidences that the neurodevelopmental outcome is better if you start KMC early, and with long duration. But for us, no, as healthcare workers in NICU, the most important thing is the baby's mortality, the neonatal mortality. It has got a huge impact on neonatal mortality. So that is why, apart from whatever you have said, those are all benefit. But the important thing probably is it decrease in the neonatal mortality, which KMC brings about. So what they have done lots of studies, and they've proved that whether late KMC initiation or early KMC initiation, at least what is the minimum duration? They say there is no such minimum duration, but the recommendation is at least how many hours per day?
1 hour.
No.
Continuous.
It is always continuous KMC.
6 to 8 hours.
Yeah, so these studies have taken the 8-hour cutoff. So they've there was a meta-analysis as well. So they have found that at least 8 hours of KMC is needed for all these benefits. So if doing 1 hour, 2 hour, 3 hour KMC per day may not be if efficient in bringing out all these benefits in the newborn. So the emphasis is on what is IKMC?
Intermittent.
No. So it is immediate KMC. Someone has answered in the chat box, immediate KMC. We are tuned to starting KMC once the baby is stable and once the mother is able to come into the NICU. So the shift is now from the routine KMC or the age-old practice of KMC to initiation of IKMC. That is why when you were telling this baby, the KMC was advised on day 9. So that itself shows the quality of neonatal care we have provided is not that great. Is it not? Day 9, yes. This baby required CPAP only for 24 hours. So there is a huge gap there. This was a stable baby, yet initiated only on day 9 of life. So the emphasis is now on immediate KMC, and that is why the concept of MNICU has come up, wherein mother and sick babies on CPAP, and they even advocate starting for ventilator babies, but all the practical things, babies on CPAP also should be started on immediate KMC from day 1 of life. If because in MNICU setup, the mother will be with the baby in same room, right? So the mother can be taken care of by the gynecologist and the baby by the pediatrician. Yes. So the concept of IKMC is one thing which you should all know. Second, probably is it is continuous KMC, at least 8 hours for our whatever benefits we have discussed. No, it has to be at least for 8 hours in a day.
8 hours.
Okay, Jose, what are the components of developmentally supportive care in the NICU for this baby? What all things you have done? You have taken care of for giving developmentally supportive care.
First one is the minimizing stress and pain, and
How you can minimize stress and pain?
that doing a prepare a environment similar to you train, like swaddling and kangaroo mother care.
No, mine before that. Before you initiate kangaroo mother care, you started on day 9 only, no?
Yes,
Kangaroo.
sir.
Before that.
Minimize handling.
What are the practical things you can do to minimize all this?
We can decrease the noise in NICU
Okay.
around it.
In what all ways you can decrease noise in the NICU?
For opening door and closing doors, not much.
Like soft close, you need doors with soft closing without making much sound. Okay, then
Hello, sir.
then avoid discussing near the bassinet. You avoid discussions, loud
Yes, sir.
discussions.
Loud discussion.
Even dropping your forceps or any metallic things into a steel tray can be disturbing to the child.
Yes.
Okay.
Yes, sir.
And the alarms, the monitor alarm, you have to make it in a what do you call low volume alarms or like visual alarms you can make. Then what are the other practical things?
Lighting.
Lighting, cycling of lighting you can do. Okay. You can create a day and night thing when you have to have a dim light.
Yes.
Then
minimal handling.
Yeah, how can you minimize how can you minimize the handling? What is the method? Clustering. You can cluster the care. Okay, clustering of the care. Then how do you manage a feed? You said feed intolerance. How did you manage the feed intolerance for this baby?
Initially, baby having mild abdominal distension, and baby suspected NEC and kept NPO for 24 to 48 hours, and then started IV antibiotics in view of suspected.
Is it the suspecting NEC and immediately treatment started as for NEC, nil for 2 days? Is it warranted, or how did you arrive at that point? Stopping for 2 days straight away. So was it that catastrophic thing? Findings? What prompted you to do all this? What were the probably when do you do that rationally?
Actually,
do this?
Needed reducing feeding volume, and initially, if feed intolerance occurs, and slow advancement of volume around 10 to.
And I'm asking what is the indication to stop? Not in your case. What do you think the indication to stop enteral feeding and to initiate antibiotics in this scenario?
Baby
I'm
having
asking what
baby
in
having
a rational situation. Indication for stopping enteral feeding and to initiate antibiotics.
Baby having non-bilious vomiting, but hello, sir.
I'm hearing. Continue.
If baby having bilious vomiting, Then and also abdominal distension we suspected, and also bowel sound. If bowel
That
sound
is
absent is
stage one NEC. Okay, right?
yes, sir.
What is stage one NEC?
Stage 1 NEC, there will be systemic signs such as hypothermia, apnea can occur, and also increased mild abdominal distension noted, and radiologically we have maybe normal or mild ileus can occur.
Okay.
In that case, we kept NPO and start antibiotic for 3 days. And after getting culture report, we should stop
Serial
antibiotic.
X-rays.
Sir?
Serial X-rays. What is serial X-rays? Does it help? Serial X-rays.
If it is developing stage 2, we can identify pneumatosis intestinalis.
No. Before that, what do you see? Before pneumatosis intestinalis.
My ileus can be mild ileus can be identified.
Find a fixed loop something. Okay, fixed loop you can see.
Yes,
Fixed
sir.
loop. Okay.
Fixed loops.
Okay. Then what is your take on ultrasound in NEC?
USG.
You got an in-house ultrasound machine in your NICU. So does it help in managing NEC?
In case of severe NEC, we should identify.
So only in severe NEC it is of help?
No, sir. If bowel wall thickness, we can identify bowel wall thickness using.
Which is better, is X-ray or ultrasound? Suppose you are, which is better? So suppose you are trained in that. Which is better?
Ultrasound should be better, sir.
Not should be. Okay. You can detect probably it is more sensitive than X-ray if you are trained in that. Okay. So feed intolerance, how do you manage feed intolerance?
Yeah, feed intolerance. If baby having vomiting and abdominal girth, we should monitor closely. And if more than 2 centimeter rise, should.
Any importance in the positioning of the baby? Positioning the baby.
Positioning.
How do you position the baby? Suppose you encounter feed intolerance. What are other things you can try?
To reduce any regurgitation or reflux, we should keep semi-upright.
A slight head and elevation you can provide. Okay.
Yes,
then right lateral position.
Oh.
Is there any advantage in evacuating the bowel? Like giving normal saline washes, saline enema, what do you call? Is there advantage?
Of course.
It seems that it is advantageous to evacuate bowel by giving saline wash, normal saline enema for the babies.
Yes.
So these things can be tried if there is a feed intolerance, positioning, and giving saline wash and so.
Okay, sir.
Okay, continue.
Coming to examination, baby was awake and quiet, and resultant state of 5. Baby was pink in color. Cry was normal, and vitals temperature 36.5 degree Fahrenheit. Warm peripheries. Heart rate 124 per minute. Regular normal volume. All peripheral pulses felt, and a respiratory rate of 42 per minute. Regular, and capillary filling time 2 seconds, and BP 60 24 millimeters of mercury, right upper limb normal, saturation of 97% in preductal and 96% postductal in room air.
Jose, your Brassilton state of 5 is not correlating with awake and quiet state. So all of you should be knowing the levels of awakeness in a baby, in a term baby, in a newborn baby. So this
Baby
Brassilton
was
is one.
crying. Baby having crying.
അല്ല baby was awake and quiet എന്ന് പറഞ്ഞിട്ട് Brassilton state 5 എന്ന് പറയുമ്പോൾ
Okay.
okay. So maybe Brazil stage 3 ഒക്കെ ആയിരിക്കും സാധാരണ awake alert ആയിട്ട് ഇരിക്കുന്നത്. ക്രൈ വരുമ്പോൾ അത് 5 ആയിരിക്കും. ഫസ്സി ഭയങ്കര ഇറിറ്റബിൾ ക്രൈ ഒക്കെ വരുന്നത് അങ്ങേയറ്റത്തെ ആകുമ്പോൾ.
Okay.
But point is, it is always better if you can mention the level of alertness in which you are examining the baby. Yes, examination as such may not be very important. Newborn short case actually. Sir, അല്ലേ?
അതെ മെയിൻലി ആസ്പെക്ട്സിന്റെ ഡിസ്കഷൻ ആണ് വരിക. പിന്നെ ജോസ്, one thing I want to ask you, how did you manage the breastfeeding? What are the points you should take care in successful establishment of exclusive breastfeeding? Right from day one.
Breastfeeding, there is good attachment position.
അല്ല അത് ശരി. Okay, then
within
preterm baby, generally you don't expect the preterm baby to actively suck at the breast.
Yes, sir.
So that is the prerequisite for, okay, so it has to be expressed.
Yes, sir. Expressed breast milk.
What is the problem in expressing the breast milk initially? There may not be any breast milk. So mother will be upset that she's not producing enough milk.
Yes, sir.
It is important to reassure her. Initially, there won't be much milk. You will produce enough milk for the baby. So you have to be supportive, and our family should be supportive, and the lactation counselor should be supportive. And she has to be, the breast should be expressed not only during daytime, even during night time. Like intermittently, it has to be expressed. Even though you don't get much milk, you have to do it so that it is easier for establishment of successful lactation. Okay, so that is important. And you said you kept the baby in Illorly for 2 days, right?
Yes.
So that time you had to advise the mother to express the breast milk, and probably she can contribute it to the milk bank. So you got a milk bank there. So that is possible.
Yes.
And so it has to be the lactation should be maintained during such gaps. Otherwise, it won't be available.
We are advising in NICU.
Okay.
Just one question. Like, what is the criteria based on which you build upon the feed? That is the mode of feeding. So you said you started off with rice tube feeding, then you went up to the Gokernam feeds, and then probably now the baby is on direct feeds, some amount of deep direct feeds as well. So what are the criteria based on which you decide what is the mode of feeding this baby has to go through?
If baby have less than 28 weeker, we are starting IV fluids. And
we're not talking about how much IV and how much enteral feeds. The baby is on enteral feeds. The baby is definitely is on some amount of enteral feeds, not about the quantity. The route of feeding I was asking.
Okay. Initially, start via OG tube and monitor for any feed intolerance, and gradually increase the feed volume 30 to.
So this being a 30 weeker.
30 weeker.
Yeah. So what is the important thing you'll have to take into consideration when you decide which is the mode? ആർക്കൊക്കെ റൈസ് ട്യൂബ് ഫീഡിംഗ് തുടങ്ങണം, ആർക്കൊക്കെ ഗോകർണം ഫീഡ്സ് തുടങ്ങാം, ആർക്കൊക്കെ ഡയറക്റ്റ് ഫീഡ്സ് തുടങ്ങാം എന്ന് തീരുമാനിക്കുന്ന എന്തൊക്കെ പാരാമീറ്റേഴ്സ് വെച്ചിട്ടാണ്?
Gestational age.
Yeah. So that is the most important thing, the gestational age. So can you just qualify that?
If more than 34 weeks, we can start direct breastfeeding. Between 30 to 32 weeks, try GK feeds and slowly hike.
There might be difference in opinion, like 32 weeks above, many are confident in starting Gokarna feeds. 30 weeks plus, still we have our own reservations. Some people do try Gokarna feeds. So above 32 weeks, yes, definitely they should not be on rice tube feeding, provided other things are uh, favorable. From 32 weeks no മേലാണ് Gokarna feeds.
GK feeds.
Hmm.
Gokarna feeds. 32 and 28 to 30 weeks.
Less than 32 weeks, probably rice tube feeding.
Yes.
Rice tube feeding, as I think latest FPNC says 30 weeks plus, you can start on some amount of Gokarna feeds. Why this gradation? Based on what?
Get sucking, swallowing, plus coordination between suck, swallow, and breathing.
Yeah, so it is the coordination, because suck might be there, swallowing is right there from yeah, first trimester on. The baby is in the fetal embryonic stage. So it is basically the suck, swallow, and breathing coordination which is important, which is usually beyond 34 weeks. That is why, apart from the gestation, any other thing which you will consider to decide on the mode of feeding? Definitely the respiratory distress, the need for respiratory support, all those things. Is it not?
Yes.
Right. So most importantly, it is the gestational age and the weight. Weight probably is in the second place, and other physiological parameters. If the baby is having tachypnea, you will not go in for Gogarnam feeds. You will just put a rice tube and feed the baby. Fine.
Yes.
Can you just elaborate on non-nutritive sucking, NNS?
Non-nutritive sucking after expressing the feed, baby put on breast, and typically that may be helping better breastfeeding. Their feeding skills can be established.
Yeah, so there is better oromotor coordination for the baby's part. Okay, because rice tube feeding, we are bypassing the suck part, the oromotor coordination, and the stimulation. So that is why any baby, for that matter, even the smallest of small babies, if the baby can be taken to mother, Allah, taken by hand, and is stable enough, you should be starting on non-nutritive sucking. Any benefit for the mother? Definitely more. Because the baby is
for mother.
For the mother, that again is a stimuli for more production of milk.
Yes.
So both ways, it is NNS is very important. So what Sir was mentioning about the developmentally supportive care, no? So that is one thing you need to start right in the NICU. So there are 5 core principles of DSC. Can you just elaborate on that? Whatever you have mentioned, but just putting them in each basket. There are 5 core principles.
First one, minimize family participation.
Yes. So one is family participatory care.
The environment, providing environment. Sensory stimulations. Minimize handling. Stress and pain will be minimized.
Stress and pain. So we are not aware. We are aware, but we don't give importance to pain and stress management in ICU. So that is second important thing. One is involve family in the care. Second is give due importance to pain and stress management. Then the environment which you are working is healing environment.
Yes. Then stimulations.
So in NICU, we give unwanted stimuli. We give lot of unwanted stimuli. At the same time, we are not stimulating the sensory system or the other. The baby is just in the cradle or in the warmer. There's no one to speak to him. There's no one to touch him. So, but he's hearing lot of noise. His eyes are exposed to lot of so much of stimulant light. So we are actually stimulating unwanted. There is some order of the order in which the sensory system of the baby develops. What happens in NICU, we are the understimulated one are always understimulated. There's no one to touch the baby, so the kinesthetic stimulation is not there for the baby. So the important is multimodality stimulation through KMC, wherein there is some amount of touch. There is some the mother is always there. The sound of the mother is there, so that protects the baby from unwanted noise, unwanted stimuli. So that healing environment is one very, very important thing in developmentally supportive care.
And also positioning the baby.
Yeah, so that all comes in the activities of developmentally supportive activities of daily living, they say. So massaging, positioning the baby. So these are the 5 core principles of DSC, which all of us should be familiar with.
Okay.
So coming to this baby, so what is the issue? Why is this baby not discharged home?
Baby having not adequate weight gain, not gained birth weight even after 2 weeks. And
is there any
now
discharge criteria? What is the discharge criteria?
if baby having adequate weight gain, like 30 gram per 30 milligram per kg per day for
30 gram, you mean?
30 gram per kg per day for minimum 3 days.
30 gram per kg is too much to expect, no? For a term baby, what is the normal weight gain you expect? 20 to 30 gram. For a preterm baby, it is roughly around 10 to 15 gram per kg. So term, it is absolute amount of 20 to 30 gram per day. For preterm, it comes to 10 to 15 gram per kg. Yeah. So roughly, this baby is 1 kg, like 15 gram increment.
Yes.
Okay. But there should be consistent weight gain. What is the other criteria?
Baby on full oral feed.
Hmm.
There is no significant feed intolerance.
The baby is stable on feeds.
Stable cardiovascular status.
Yeah. So all the diseases have been taken care of. The baby is immunized. So there was a question in the chat box. What are any immunization specifically you want to avoid in a preterm baby? Do you give OPV to a baby in NICU? Those were the questions in chat box. Would you like to try?
Baby have given OPV and BCG. Hepatitis B, as baby having no adequate weight. Hepatitis.
So hepatitis B, they say less than 2 kg, but now they say we need to give hepatitis B vaccine for all babies, at least by the time they are discharged, irrespective of weight.
Muscle mass.
No, those are all misconceptions. The latest thing is you should be giving them vaccine, hepatitis B vaccine, at least by the time the baby is discharged. Okay. Okay, so the baby is gaining weight consistently. What else? What else?
Weight gain.
Baby is able to maintain temperature by herself. You don't require a warmer.
Screening completed.
Screening is completed. So coming to this preterm baby, what are the important screening you will do?
Retinopathy of prematurity.
Okay. Can you just highlight which group will you?
Less than, according to RBSK, less than 34 weeks and less than 2 kg babies are screened for retinopathy of prematurity. And also 34 to 36 weeker with the risk factors and received auto support.
Okay.
And
for smaller babies, what time?
Smaller babies 2 to 3 weeks after the birth screen for
to be specific, when you mention smaller babies, less than 1,200 gram or less than 28 weeks, you need to screen them early.
Yes.
Right. So then in any other screening, one is ROP.
Hearing
Screening. So these are all high risk babies. They may not be, we routinely do OAE, autoacoustic emission, but for all high risk babies, you need to get at least ABR or a Beradan. Okay. So the OA screening is done for all babies in a hospital, but these are special group in which you would require, you need to rule out the central cause, sensory neural hearing loss as well. So you would require AABR, or if baby's weight is good enough, BERA also.
Yes, ma'am. Then metabolic screening should be completed.
This being a preterm, you have mentioned about ROP screening. Anything else with respect to the neurological development, which has got an important bearing on the development?
Neurosonogram.
Yes. So neurosonogram
should be done on third day and after 1 week and 1 month.
Corrected gestation of 40 weeks to look for periventricular leukomalacia. Fine. Then any endocrine thing, endocrine parameter?
Thyroid.
Yeah. So in a preterm, you need to repeat thyroid. You should not be, it is not enough that you do it at birth. You need to repeat them
2 weeks.
At least after 1 month.
Okay.
Okay. Then you need to screen them for metabolic bone disease or osteopenia of prematurity. Okay. So these are the essential screening. Sir, anything more, sir?
I mean, regarding what are his IVH prevention strategies will adopt in this baby?
IVH prevention bundles.
Yeah.
It
the components of that.
And antenatal intervention, steroids, and also delayed cord clamping, and avoid hyperoxia, and avoid hypothermia.
And not only steroids, also magnesium sulfate has got a bearing on reducing the IVH.
Yes, sir.
Then
from NICU, minimal handling and avoid sudden changing of positions.
Okay.
And also midline position should be maintained. And head and elevation, slight head and elevation.
Okay.
Avoid fluid boluses.
Blood products. Avoid
fast fluid boluses. Then your soda bicarb, no hyperosmolar things should be avoided.
Yes. And also provide kangaroo mother care can prevent IVs.
Okay, and also like treating PDA appropriately, also to some extent will reduce the incidence of IVH.
Yes.
And regarding you talked about so many advantages of breast milk. So is there any role of breast milk in IVH?
IVH breast milk.
It seems
neuroprotection.
No, it seems there is a role for instilling breast milk through the nostrils. I don't know, is it fully acknowledged? It seems it can supply in severe IVH for regeneration, can supply stem cells, it seems, can pass through the cribriform plate and reach the brain, it seems.
Okay, sir.
Okay, so you can look up strategies of prevention and managing IVH. Then, okay, continue.
Yes, sir.
Ma'am.
So this baby is about
regarding a weight gain. What is the child gaining weight normally?
No, sir. Baby
you
having
plotted the growth in the chart, chart for this baby.
Baby's weight now 1.255 kg and below third centile, and birth weight was 1.345 kg between third and 10th centile. Now
so baby has gone down.
Yes, now decreased.
How many days now? Age of the baby?
24 days old.
The child is not gaining weight appropriately.
Yes, sir.
So what is your
What are the
advice?
what are the reasons probably for that, for not gaining weight? What all things you'll consider?
Maybe adequate concurrent care, adequate calorie intake, adequate feeds.
What is the expected calorie for a growing preterm?
100 to 120
Yeah, 100 is
kilocalories.
not enough. Around 130 kilocalories you need to supplement. So coming back to the question, how will you supplement and protein? What is the protein requirement?
4 gram per kg per day.
So how are you going to supplement this?
It's
In this baby, what are the things you would do?
more milk, human milk fortifier can be
You
added
can
to
fortify. So how much of protein is there in one sachet, which is commercially available?
144 kilocalorie and 4.4 protein.
144 kilocalorie lello.
4.4 gram protein.
No.
Lactodex
144 kilocalorie is too high, no?
7.
So you need to calculate how much is the required amount, calorie requirement and protein requirement, how much you are getting from the breast milk and how much you are going to fortify it with. So in this particular baby, you have probably you are having a calorie gap, you are having a protein gap. So we were asking you, like, how are you going to bridge this gap? Either by, what are the methods? One is fortification of the milk.
Adding
Second thing is
adding supplements, calcium.
Supplements are all vitamins, no? Supplements are may not provide you with calorie and protein.
Prevent hypothermia.
Yeah. So that is what Sir was asking. What are the causes for a poor weight gain in postnatal age? One is undetected hypothermia.
Increased metabolic demands.
Anemia could be one. Infection could be one. Okay. Apart from the feeding, inadequate feeding, these are all organic causes which can lead on to poor weight gain. So you need to rule out all organic causes. You need to calculate the calorie protein requirement. You should know roughly 130 kilocalories per day. Calorie and protein is roughly 3.5 to 4 gram per kg. And you should know how much you're supplementing from through breast milk and how much you need to bridge the gap through milk fortification. Then is there any other way out? You can increase the volume of milk you are giving. No, usually we stop with 150, 160 ml per kg, but you can go up in preterm babies. Sometimes you end up giving 180, 200. So one is you can increase the volume of milk, fortify the milk you can give. Then what is this concept of hind milk?
Hind milk help in weight gain.
Yeah, why?
Rich in fat.
Yeah. So that is one thing. Practically, you can rich in fat. So practically, you can ask them to express we don't know at what point of time hind milk starts pouring in, but roughly around 3 to 5 minutes, രണ്ട് breast express and keep it in one container. And the milk expressed later on probably is the hind milk and which is considered to be rich in fat. So these are all modalities which we can practice to improve the weight gain. Then, of course, strengthen the KMC, implement it effectively. So this baby having, we are sure this baby is having EUGR, no? Extrauterine growth restriction. The baby has not regained birth weight, which is very concerning. The head circumference has fallen by 1 centile. Everything, the length, weight, and head circumference have fallen by 1 centile each, which is really concerning. So these are the methods you would probably adopt to overcome this.
Yes.
Jose, when do you start iron supplementation for preterm babies?
After 40 weeks of 3.
This baby is 30 weeks, no? 30 weeks of
30
gestation.
weeks.
So postnatally, when will you start? At what age?
3 weeks.
Okay,
Three
after
weeks.
after full enteral feeds. Okay.
Okay,
After 3 to 4 weeks, you start iron. Okay, how do you monitor whether child is getting adequate iron? What is the best way of monitoring whether the baby later? Okay, say after 1 month or so, you would like to know whether child is getting adequate iron, or how do you know that? Is it hemoglobin or
HB,
is it a blood
HB.
disease? Is it HB? Do you think that this iron will go and convert to hemoglobin immediately? Why do you want to give iron for a preterm baby? Is it to increase the hemoglobin immediately?
Iron for neuro.
No, it is to replenish the iron store so that once the erythropoiesis is
Yes.
restarts, it provides iron. So you have to check ferritin rather than
Iron.
hemoglobin. So similarly, when you are giving calcium and phosphorus, vitamin D, okay,
Yes.
how do you monitor whether you are providing adequate calcium and phosphorus later when you follow up the baby? What will you check?
Any features of rickets?
Very unlikely if you are giving vitamin D and this thing, you may not clinically evident osteopenia, you may not pick up.
Test ALP can.
You can see alkaline phosphatase and you can give phosphor. Phosphate you can estimate. So if it is say probably less than more than 800 ALP, probably you are giving less. You have to increase.
Yes.
So that's how you monitor.
Sir, I think it's 9 o'clock. We are
Wind up here, Deepa. Can we wind up?
Babu, how many minutes, how many slides more are there?
So,
Slides ഏതാണുള്ളത് ഇനി കൂടുതലായിട്ട്?
diagnosis.
അതിന്റെ വലിയ കാര്യമില്ല ഡയഗ്നോസിലൊന്നും.
Any important point you would like to, maybe we can take another 1 more 10 minutes, I think.
Okay. You can complete your slides. We can chip in whenever. Complete Deva slides complete ചെയ്തോട്ടെ. Then we will add.
Okay, sir.
Jose pass
Okay,
വേഗം continue ചെയ്തോളൂ.
Head to foot examination, head size normal for gestational age, shape was normal. Anterior frontally open, measuring 1.5 into 1.5 centimeter. Posterior frontally admits tip of little finger, no facial dysmorphism, eyes, ears normal, oral cavity, no cleft lip or palate. Skin appears normal for gestational age. No features of osteopenia. Chest decreases subcutaneous fat, abdomen normal, back thin line of hair, umbilicus healthy, no erythema or discharge, limbs normal. Genitalia.
Umbilicus, Jose, will you advocate milking of the cord? Cord milking, will you advise? Is it advantageous?
No, sir.
You will not advise.
Milking of cord, no.
Blanket at which gestational age it is not advisable? It's not advisable less than in extreme preterm, maybe it is not advisable. It increases the risk for IVH.
Okay, sir. Okay.
In other age group, there is
sir. Less than 28 weeks.
Not advisable. Okay. Okay, continue.
Okay, sir. Genitalia normal, male genitalia, one testis and descended anal orifice present. Hips normal, no development dysplasia head. Spine normal, respiratory system, abdominothoracic type of breathing. Chest wall bilaterally symmetrical, chest moves equally bilaterally, normal vascular breath sounds. Serious apex in left fourth intercostal space lateral to midclavicular line, normal character, S1, S2 head normally, no murmur. Abdomen soft, non-tender, no organomegaly. Umbilicus normal, hernial orifices normal. Free bowel sounds normal. Nervous system, baby awake, quiet with eyes open, moving all four limbs symmetrically and spontaneously. Lying supine with flexion at upper and lower limbs. cranial nerves, 1 not tested, 2 pupillary reflex present, 3, 4, 6 not osis skin, extraocular movements normal, rooting and sucking reflex present,
Okay, you can pass. You can pass this. അടുത്ത slide go.
motor function, posture, flexion at upper limb and lower limb, tone, adductor angles, adductor angle 130 degree, popliteal angle 120, dorsiflexion angle
This-
70.
Okay, you can skip. Go to the next one.
Neonatal reflex, rooting, sucking, palmar and plantar grasp reflex.
What Moro do you want to test? Moro
Sir,
response test ചെയ്യണം.
34 weeks now, baby 34 weeks.